So, as we always start, just please note that everything we share here is for educational purposes only. This is not intended as medical advice. If you do seek if you do require medical advice, please do seek so from a professional, whether it's your existing healthcare professional, or functional medicine practitioner, or nutritionist. Any of the testing that we talk about here, or supplementation or medication, again, not to be intended for treatment or recommendation should you have any hormone imbalances currently. So please take this. Do take this information as a means to further your knowledge and also help you become your own detective of your health, and seek out the professional advice that is needed to get you better. So may I just ask if everyone can please mute their microphones, as I'm getting some backdrop noise. All right, thank you. So in episode 1, just to give you a recap, we talked about the foundations of hormones. So we talked about what functional medicine is, which is root cause medicine, which essentially is the science of creating health rather than just preventing disease, and where we think about not just the organette in question with regards to imbalance, but we look at the entire terrain, the entire environment that surrounds it. So we look at the body as a holistic integrated ecosystem. We talked about old versus new thinking with regards to hormone balance, and we also talked about how hormones are made. We dove into the complexity of the steroidogenic pathway and the different roles that these hormones play and the subtle influence they have on our entire body. Then we talked about common patterns of imbalance across those different hormones, and how do we test them effectively, and how to address that imbalance. So for today, we're going to shift focus more towards the hormones that are involved in the menstrual cycle regulation. And while when it comes to menstruation, we tend to think, oh, it's mainly estrogen, progesterone, LH, FSH. There's actually a lot more hormones that influence it that we had discussed in the previous session that give rise to an imbalance in that cycle. We're going to talk about PCOS, which is one of the most common hormone imbalances in premenopausal women, and how to really truly diagnose it. Discuss the role insulin, adrenal hormones, and gut microbiome play in the health and balance of our menstrual cycle. And then we're going to review a very short case study outlining testing and treatment. Just a kind reminder for everyone to please mute your microphones. Okay, so as a recap, our old thinking was that when it comes even just for our menstrual health, that our brain through the hypothalamus and the pituitary control the release of estrogen and progesterone in a cyclical fashion with the support of LH and FSH in order for us to ovulate and also have a full healthy cycle. Now this understanding has expanded because we know that this axis doesn't actually live in isolation. And in fact, it's a much more complex ecosystem in which inflammation from either within the immune system or triggered by the gut, so the gut microbiome, can also impact the axis and impact the health of our menstrual cycle. Also, our liver, our capacity to detoxify and recycle our hormones, our adrenal function, our stress hormone, and its ability to regulate the release of those hormones and the communication signaling that's going on between the hypothalamus, pituitary, and the ovaries. Of course, the thyroid plays a very important role, as well as insulin resistance and insulin in particular. In particular, insulin resistance, and we're going to dive into this when we talk about PCOS. So as a reminder from last session, the common patterns of hormone imbalance that we tend to look at are low or high thyroid, high cortisol or low cortisol, which is coming from our adrenal glands, insulin resistance as it relates to the organ which it releases, which it's released from the pancreas. And then we talk about sex hormones, so progesterone, estrogen, and androgens. Now, actually, prolactin is missing out of here, which again is an enzyme that's produced by the pituitary, and that also does have a role to play in our menstrual regularity. We, of course, can't cover all of these in a short 45-minute session, but the point I wanted to highlight here is all of these patterns, whether one or multiple of them are occurring in someone's health, they all will impact our cycle. So our cycle, in a sense, becomes a vital sign. So let's get reacquainted with our period a little bit. Take you back to those biology classes. So your menstrual cycle is a vital sign. Okay, just like your heart rate, your body temperature, your respiratory rate, your blood pressure, really you need to start looking at it as a vital sign. If there's anything off with your menstrual cycle, i.e. it's behaving outside the norm of what norm is for you, and I'll come to talk about this in a second, then you need to think something must be wrong. And I want you to always keep that detective hat on. So it involves, this is not even a full comprehensive list of all the organs and hormones that are involved in regulating the cycle. However, these are the priority ones that we look at. And as you can see, it involves a very intimate sort of interaction and interplay between those hormones and the organs in which they're released from. And any irregularity or abnormality really should signal there's an underlying health problem. So it might not be a problem in the ovary per se, but it might be a problem in the other organs that control it, whether we're talking about the pituitary or we're talking about the adrenals or we're talking about the gut. So if we look at the periods tend to range between 28 days to 35 days. Everyone cycle length is normal to them. Of course, any change from what is normal, then that's a signal. Okay, so it's not that everybody has to have 28-day cycles and that everybody has to have their period exactly on the same day, every time. So plus minus a couple of days here and there is still acceptable. Not everyone ovulates on day 14. Everyone's ovulation pattern might change. And so we need to become aware of our cycle. And there's lots of great apps like Clue and Flow that helps you track your cycle. And I really encourage you to get familiar with your cycle and start tracking it, because that really helps you not just for your health when it comes to pregnancy and fertility, but overall well-being, so that you know if that vital sign is giving you a clue. So day one of your cycle is when you start your bleed. And at that point, both estrogen and progesterone are at their lowest level. Okay, so whenever we ask people to measure their hormones, especially in blood, there is a reason why we ask at different times at different days of the cycle, because we're trying to capture the peak of the hormone in that particular period, so we know whether there's a problem. So what happens is that estrogen, progesterone drop, and then when those drop, it helps the release of the release of the follicle stimulating hormone from the pituitary. Okay, this FSH, it helps stimulate the growing follicle inside your ovary, and it also helps the release of estrogen, estradiol, E2. As this peaks, when estrogen peaks, then that stimulates the release of luteinizing hormone, again from the pituitary. And what LH does is that it activates the corpus luteum to produce progesterone now that had ovulation occurred. So when we have the peak of estrogen, peak of LH, peak of FSH, ovulation happens, and then that sac becomes the corpus luteum, which starts to produce progesterone that is there to help maintain pregnancy should implantation occur. Okay. And now testosterone is not on this picture, but testosterone generally maintains a very low level and has a very small peak around ovulation as well, very small peak around ovulation. And you can notice that your body temperature changes during ovulation and the luteal phase. So that's when we talk about basal body temperature mapping, where that is a way in which you can measure whether you're ovulating or not when you see an increase of about a degree in body temperature. So there are many ways you can test for ovulation. Check for your ovulation. You can use ovulation sticks. So the LH sticks, you can use the ones that you pee on. Then you can use basal body temperature measurement. You can also measure your cervical mucus fluid, which becomes much more clear and sticky around ovulation. Okay. The key thing to remember about our periods is that healthy ovulation is key to a regular cycle. Okay, so if we have any issues with our ovulation, then we are likely not going to have a normal cycle, and that is going to have a knock-on effect on the rest of our body. Now, why healthy ovulation might be impacted, we're going to talk about this next. So clues that something is not right. If you have late or early periods, okay? If you have no periods at all, which is amenorrhea, and you could have, there's called amenorrhea and secondary amenorrhea. So primary amenorrhea is when you don't get your periods at all from the get-go, and then secondary amenorrhea is where you lose your periods sometime later in life, right? So it could be because you came off the pill. It could be because you went through a period of extreme stress. It could be because of significant weight loss or significant weight gain. So that's the no periods piece. Then you might have light, very light, or very heavy periods. Okay, either way, that is not normal. Mid-cycle, so if you have a mid-cycle bleed, so around ovulation, or you have a continuous bleed, perhaps because there's a presence of polyps or fibroids. If you have a prolonged bleeding window, so normally averages you bleed between 3 to 5 days. The first two, so day 2 and 3 are your heaviest, and then it starts to wean off. If you have a bleed beyond 7 days, then that really needs to be checked. If you have menstrual clots, so you need to have fresh, bright blood the majority of your cycle, and there should be no clotting, so no dark blood clots. If you have premenstrual syndrome, or PMDD, is where you have extreme breast tenderness, cramping, perhaps diarrhea. You might have agitation, or you might feel extreme emotional swings. Any that, or migraines. Again, these are symptoms that something is not right with your hormone balance. If you have severe period pain, that is not normal. If you have to rely on painkillers to manage your way through a period, then there is something wrong with your hormone balance. If you have pain during sex, that again is a sign that there might be low estrogen, and so reduced lubrication, vaginal dryness, and that leads to pain during sex. If you have cystic acne, which is, and especially it's around the jawline or in the cheeks or on the back, that also may be a sign of hormone imbalance and excess androgens, in particular testosterone. So what commonly we do is when we have, in the conventional setting, what happens is you have irregular periods, you go in to see the physician, and they're like, okay, are you trying to conceive? No, then there you go on the birth control pill. And if you have extreme pain, have a painkiller. Or if acne is present, we treat it with an antibiotic. Right? So we're constantly medicating, kind of playing a game called whack them all. So wherever the problem is, I'm just going to give it a pill and hope it will go away. But that's the point here that I'm trying to make, is that you're not asking why. When we do this, when we just try to regulate our period simply by adding a pill or any medication, or treat a symptom as a result of hormone imbalance, without asking why, there lies in the problem. We're not fixing the root cause of the problem. And really, this comes at a quite significant cost. So birth control pills, to be clear, they interrupt the signal that goes between your hypothalamus, pituitary, and ovaries. So you actually end up with a withdrawal bleed. It's not an actual bleed. It's not a true natural bleed, right? So that's why a lot of people, after they come off the birth control pill, especially if they're on birth control pills that are very low in androgens, i.e. they have very low levels of testosterone, such as Yasmin, what happens is they end up with a rebound, so excess androgens released after they come off the birth control pill, and they end up with PCOS, post-pill PCOS, right? And they might lose their period, or they might have pain in their period, or regular periods, and so on. Or they might develop acne. Also from birth control, and for example, use of Roaccutane to treat acne, then you end up with significant nutrient deficiencies. So B vitamins, magnesium, selenium, zinc, vitamin C, CoQ10, all of those things. And these are essential, really essential nutrients for the healthy function of your mitochondria, so production of energy, for detoxification in the liver, for hormone production, and most importantly, immune health, which of course is the hot topic nowadays. What about non-steroidals as painkillers? They deplete vitamin C and iron. Antibiotics, they disrupt your entire microbiome, and they cause a widespread indirect effect that I'm going to discuss later on. So the question we really need to ask ourselves, if there's imbalance, is what is driving that imbalance? Okay, do I have PCOS? And of course, PCOS has also many drivers underlining it. This is just kind of the syndrome we give when we have certain constellation of symptoms associated with hormone imbalance. But it is one of the most common ones. Do you have too low body weight or too high body weight? So is it obesity or underweight? Do you carry out extreme exercise? Are you under incredible amounts of pressure, or have you underwent a major life trauma? Is there hyperprolactinemia, maybe because there's a minor tumor in the pituitary? Is there thyroid dysfunction? Could be thyroiditis, could be hyperthyroid, could be hypo, could be autoimmune condition. Are you, of course, experiencing perimenopause, or is there low ovarian reserve? So the ovaries are failing to produce any more follicles, or you have premature ovarian failure. There's, of course, anatomical issues that we need to consider, like polyps, fibroids, and endometriosis. We're not going to cover this in today's topic, but we will next month. So again, we need to put our detective hat on and think about, okay, well, what am I doing and what am I exposing myself? What am I doing on a daily basis that is impacting my hormones? And we talked in the previous episode on how sensitive hormones are to our environment and to the daily activities that we do, from eating to the way we breathe, our sleep patterns, level of stress, exercise, and so on. So let's dive into PCOS. So PCOS is polycystic ovarian syndrome. And by the way, you can have PCOS without actual cysts in your ovaries, but nonetheless, that is the name, polycystic ovarian syndrome. And the underlying drivers a lot of the time are insulin resistance, inflammation, and hormone dysregulation. So that's what describes the systems view of PCOS. So it's really it's the most common endocrinopathy that affects women. About 5 to 10% of women experience PCOS. It's very chronic and often involves a hyperadrenergic state, i.e., elevated levels of testosterone. Women with PCOS may present with obesity. They may present with amenorrhea, i.e., no periods. They may present with oligomenorrhea, infertility, or androgenic features like excessive hair in unwanted places, like the chin or the chest. Or the lower part of the tummy. They could also have cystic acne, as we talked about. It also increases your risk of both diabetes and cardiovascular disease, because the underlying driver commonly is the presence of insulin resistance. And there's a risk of, actually, a study showed that there's a higher risk of a stroke, 7 times more with patients with PCOS. So it really also increases the risk of endometrial cancer, because again, the balance that hormones bring to the lush environment of our uterus and our ovaries is necessary to prevent the abnormal growth of cancer cells. And but the challenge with it is it's very, very difficult to diagnose, and it affects are very multifactorial. Okay, so you can have it can lead to people can present with infertility, but their actual problem is PCOS. People can present with depression, but the underlying problem is actually PCOS. People can have type 2 diabetes, but actually the precursor to type 2 was that they had PCOS that caused type 2 diabetes, and we need to kind of go a few steps back to resolve it. So sometimes it takes up to 3 years for a patient to be diagnosed with PCOS. Now, when the way it presents is very different in individuals. So in the past, we used to think, oh, if you have PCOS, you have to be obese, you have to have acne, you have to have hair. That's not the case, right? You patients come in all uh, shapes, sizes, and symptoms. So they can have weight gain or obesity, but they can also be on the skinny side. They have menstrual irregularities or completely no periods. They can have ovulatory periods or anovulatory periods. They can have heavy menstrual flow. They can have mid-cycle bleeding. They can have acne. They can have hair. They can have hair loss instead of actually excess hair. They can have a history of cysts, but also no cysts present. There's a history of recurrent miscarriage. That also is a signal of presence of PCOS. Infertility and estrogen excess, where you have extreme pain and tenderness in the breast, or development of fibroids in the breast tissue, or the development of PMS, or, for example, migraines, hormonal migraines. So we know that when we are treating PCOS, we need to think about inflammation and what we now call inflammaging, which is the amount of oxidative stress and your body's antioxidant capacity, your gut health, your intestinal permeability, as well as hormone balance, insulin, and cardiovascular health. So it's a really multifactorial syndrome, and we have to approach it as such with a multifactorial treatment approach. And insulin resistance or hyperinsulinemia, it occurs in a large percentage of women with PCOS. Okay, it's like more than 70% of women. And there's two parts to this that is important for you to note. One is that cells in the body, including the ovaries, become very resistant. They become very resistant to the messages from insulin. So to take in the glucose. So the body's like, I can't take on any more glucose that's in the blood. So the blood sugar rises. And so as a result, the pancreas is like, okay, well, I need to pump in more insulin in order to push more glucose into the cell. And that's how you end up with hyperinsulinemia. A big culprit in that, by the way, is stress. So when you have excessive stress or chronic a prolonged stress, that elevated level of cortisol in your body causes the release of more sugar into your blood, and that then results in more insulin being released, and then you get into this vicious cycle of insulin resistance. So when people come to me with PCOS, often they're often been treated with a birth control pill as a first get-go. Let's regulate your cycles, and that will make it go away. Or let's give you metformin because we know insulin resistance is underlying it. And then for some where there's, for example, extreme androgen excess, high testosterone, they might use drugs like aldactone or so on to suppress the testosterone. But birth control, whether we're using birth control or metformin or aldactone or whatever, it's really not doing anything to prevent or to cure or prevent or fix PCOS. Okay, it doesn't actually address the root cause, and we're not um, helping you find balance and harmony so that you can recover from this for the long term. So it's just simply a management tool, and it's just suppressing, masking the real problem. So when it comes to PCOS, this is a chart. I love it from Dr. Lara Biden. I've put the book there as a reference for you. She's a great resource. If you go to her website, there's tons of information that she posts on a regular basis. But this is a flowchart that she developed, which I think is really kind of captures the different types in which you can develop PCOS to give you an indication of the multiple causal factors that can drive PCOS, but also the constellation of symptoms that can occur under the umbrella of PCOS. And by the way, you can have more than one type. So it doesn't mean that you're either insulin-resistant PCOS or post-pill PCOS or inflammatory. You can actually have multiple of those. But the way we think about it is a patient comes in and you have irregular periods or have androgen excess, signs of androgen excess. If they don't have any irregular periods, if that the answer is no, then that's no PCOS. But if we go down the red arrows or the sort of pinkish arrows, then if those irregular periods are present, we have androgen excess, then the first thing we need to check is, do they have insulin resistance, right? So we need to check your HbA1c, your glycated HbA1c, your HOMA score, and so on. So we need to really, fasting insulin, we need to address that. And then we go to the next step. Well, okay, were your periods regular before the pill? Have you been on the pill? And were they regular before the pill? And if they were irregular before the pill, then it's just that the pill would have exacerbated the problem. If they were regular before the pill and then you've lost them, then that's a post-pill PCOS. Okay. Now, we also ask, but we check for all of this. So do you have signs of chronic inflammation? And these could be things like brain fog, constipation, bloating, any sort of symptoms in the gut, any unexplained rashes, headaches, difficulty sleeping, any source of chronic pain. Then we talk about inflammatory PCOS. Then we look at, is your DHEA elevated? Is your DHEA is the only high androgen? Apologies for the typo. So DHEA, if you recall from our previous talk, it's the precursor to testosterone and estrogen. That's how we make it. So we go DHEA, testosterone, estrogen. So is DHEA the only androgen elevated, or is also testosterone and DHT and estrogen elevated? If it's only DHEA, then that's an adrenal PCOS, because that's driven by the adrenal gland, because DHEA is produced by the adrenal. And then if, for example, for some reason you're actually all of these, you answer no to all of these, right? So you don't have insulin resistance, your periods were regular before the pill, so on and so forth. Then we question, okay, well, is it truly PCOS or something else? So is it a hidden cause of PCOS? And this is where we go deeper to look for thyroid imbalances. We look for a prolactinoma, as I mentioned before. Is there an autoimmune condition going on? So that's where we start to dig deeper and deeper. So let's talk about insulin resistance for a second. So I did cover this in our previous talk, but I just want to highlight it again here, just to underscore the importance of this mechanism in promoting PCOS. So the problem with when you have, I've described how hyperinsulinemia occurs, but what it does is when it comes to the hormones, it causes a huge production of testosterone in the ovary. Okay, and this leads to several symptoms of PCOS that we talked about. So things like acne and facial hair growth and so on. And also this causes, it disrupts the signal from the brain that are designed to choose, one egg to develop to maturity. So instead of developing several small follicles, maybe you won't even grow, instead of growing one large enough for ovulation. Okay, so it disrupts the signaling that's going on from the brain to the ovary to create healthy eggs. The other things that it does, it also, as I mentioned before, is that it decreases sex hormone binding globulin, which is think of it as the bus that carries testosterone and estrogen around the body and then drops it off wherever it's needed. So if we have a reduction in the number of buses going around to carry our hormones, then we have more free hormone to exert its effect, and that's when we have those excess symptoms. Okay. It also increases that increase in free testosterone also increases the conversion of testosterone to estrogen, and then we have an estrogen dominance scenario. And then as a result, our progesterone is lowered, and then we have problems with our ovulation and our cycle overall. And that also impacts our sleep and our mood and so on. So it's really important that when we think about insulin resistance, when we think about PCOS, we think about insulin resistance, and then when we think about insulin resistance, we need to look at all the areas in that steroidogenic pathway that insulin resistance can impact, right? Is it impacting testosterone? Is it impacting testosterone conversion to estrogen? Is it impacting the reduced production of progesterone? Is it impacting the ovulation, follicles growth? So, or all of them, right? We have to explore all of those. Then we talked about stress last week. And again, stress is very, very important because the adrenal glands, they're responsible for at least 20 to 30% of elevated androgens in PCOS. Most patients I see have both PCOS and some form. Actually, in the case you'll see now, it started with adrenal PCOS and then moved on to inflammatory and so on PCOS. So the adrenal gland produces DHEA, which is 80% of it is in the body, and 25% of and then also 25% of circulating testosterone. Okay, so most stress drives up our androgenic hormones. The more our weight, skin, and hair growth is affected. So more stress means more DHEA, means more testosterone, and that results in all of the symptoms. And then chronic stress on the other side also leads to a phenomena called cortisol steal, which we talked about as well. And that really contributes to reduced progesterone production because it steals away from the precursor, the building blocks for progesterone to make cortisol. And thirdly, of course, it impacts insulin, as I mentioned earlier. So let's talk about also the microbiome. So we touched upon this a little bit, but when it comes to PCOS, actually, the role of the microbiota is really important. So that's the bugs, bacteria, fungi, viruses that live in your gut that are essential for human life. So the emerging research shows that most women with PCOS have increased markers of gut permeability or imbalance in their gut flora, and you'll see that in the case study. So this is a great article if you guys want to read it. It's called "The Role of Gut Microbiome in the Development of Insulin Resistance and the Mechanism Underlying PCOS." So what happens is, if you have gut permeability, and I'll show you this image. So if you have reduced diversity or an overgrowth of bad bacteria and you have increased gut permeability, so gut permeability, the best way I can describe it to you is think about your gut lining as the screen door that you have on your garden, by your garden glass doors, right? So it keeps bugs out, but air can come in. When you have holes in it, bugs start to come in. That's what happens when you have gut permeability. So things that are not supposed to come in to the circulation start to come in and cause inflammation. So this results in an activation of the immune system. So it leads to chronic inflammation, which then drives insulin resistance. That drives more testosterone to be produced, and that disrupts follicular development. And then we have a problem with ovulation and therefore an unhealthy cycle. So it's really important that when we're looking at patients with PCOS, we take a very thorough history about their gut and we actually test their gut, even if they may seem to be asymptomatic. So let's talk about a really fun case study. So this is a patient that is a 20-year-old female. She came to me with a history of chronic stress and antibiotic use. Okay. So remember from our previous talk, I explained the way in which in functional medicine we take a very, very thorough history, starting from preconception. So, what has happened in the womb, what is your genetic predisposition, what was your birth like, how was your early years, teenage years, and from a health perspective, from a dietary perspective, from a sleep perspective, exercise perspective, emotional well-being. So we take all of that into consideration. Now, the key things I wanted to highlight for you here is in this female, she had a very history of very chronic stress and excessive antibiotic use for recurrent infections. So the main symptoms that she presented with are irregular, painful periods, very painful periods. They were irregular. They're accompanied with cystic acne, significant mood swings, especially pre-menstruation. So the week before, it's extremely irritable. Fatigue, poor sleep, constant bloating, and frequent constipation. So I normally ask my patients to send me all tests that they've done before. So the year prior to coming to me, she had done some tests, and those tests a year ago had showed adrenal imbalance. There was elevated DHEA and cortisol, both hormones released by your adrenal gland. There was also presence of insulin resistance and significant vitamin D deficiency. I bring vitamin D here as an important factor because the ovaries require vitamin D for follicular development. It's really, really critical. So if you have vitamin D deficiency, that will impact your cycle and your ovulation. Her thyroid function was normal, but as she shared with me the blood test over that year that she carried out sort of every 3 months or so, we were seeing a trend towards hypothyroidism with an increase in the antibodies. The lipid panel was remarkable. It was all normal. Kidney was normal. Function was normal. The prolactin was on the high normal side. Okay, so it wasn't above normal, but it was elevated. So it's not optimal in that sense. And then we saw an elevated 3 months later. So that was basically would be half a year before I had seen her. The testosterone had started to creep up, so the free testosterone, and also the sex hormone binding globulin dropped. And again, insulin resistance drops sex hormone binding globulin. So, and generally it wasn't a very healthy lifestyle that she was leading, but most importantly was the chronic stress. So what did we do? Essentially, we did the Dutch plus test and the gut analysis that I talked to you about. Okay, so with the Dutch plus test, which is a saliva and urine, dried urine, and saliva test. And so what we did is in those Dutch tests, it showed very much a very complex picture of PCOS. So she had reduced progesterone, likely driven by cortisol steal, as well as the excessive androgens and estrogens. There was very high testosterone levels, as you can see here, as well as the way she was breaking down her testosterone. It was being broken down to the unhealthy form, which is actually more potent than testosterone itself. It's called DHT. And so when DHT is more favored as a breakdown of testosterone, that causes even more symptoms of androgen excess. Okay, we also see that the aromatase enzyme that converts testosterone to estrogen, that's upregulated because of insulin resistance, and estrogen is really, really high. Okay, so that's high estrogen dominance going on. And then, and we saw that the breakdown, we touched upon this last time, she was breaking down her estrogens predominantly. There wasn't a true let's say preferential breakdown towards the healthy form, the green form. There was a significant amount of 4OH being produced, and this is the toxic form of estrogen that can lead to DNA damage and increased risk of breast cancer. We also saw that her methylation activity, so her ability to then neutralize these metabolites and get rid of them, was also not very effective. And that's because we did some genetic testing to check if the enzymes that are responsible for clearing those toxins are those metabolites are functioning effectively, and they weren't. Okay, so her phase 2 detoxification was working at a very reduced capacity. So we can see there's a lot of problems that we needed to address. We needed to work on the liver detoxification. We needed to work on the adrenal glands. We needed to work on hormone imbalance internally. We need to work on insulin resistance. We also, part of the Dutch test is we look at the adrenal gland, and you can see here stress hits the hypothalamus, activates the pituitary, and hits the adrenal, and then you release DHEA and cortisol. And as you can see, both DHEA is extremely elevated, and cortisol itself is elevated. And really the clue here is you can see that her pattern of cortisol, it does not follow a normal pattern. So it's very high throughout the day. It needs to be between those two gray lines, as you can see here. So it needs to peak within 30 minutes of waking and then naturally decline until you fall asleep. Another point I didn't mention here is actually her melatonin was low, and that would have impacted her sleep capacity at night. And then we looked at her gut, and this is not the full test, but I just wanted to highlight to you that when we did this stool analysis, just looking at the microbiome, I'm not addressing the functional aspects like her digestive capacity and all of that, which also had issues, but just the microbiome had significant dysbiosis. So there was an overgrowth pattern in both the good and the pathogenic bacteria in the gut, which are driving systemic inflammation that would have contributed to PCOS as well. So what did we do? As we discussed last time, we treated the gals. We treated the gut, we treated the adrenals, the liver, and we improved the sensitivity to insulin and sugar. So what we did is we did a lifestyle intervention to start, and we basically did an overhaul of her nutrition. We worked on a whole foods anti-inflammatory diet, which was plant-rich, not plant-based, plant-rich, high in fat and quality protein with very low carb. The carb was mainly coming from vegetables, so not much grains. And of course, no processed food. We worked on building resiliency. This is really important. And And thank you, Zenia, for mentioning that, because for me, in my practice, working on your well-being, your sleep, your nutrition, the quality of your relationships, your exercise habits, and your stress management is so critical before we start to dive into any therapeutic intervention, because those pillars are what define your health on a daily basis. So we worked on building stress resiliency with journaling, meditation, breathing, techniques, and that she took on to really well. We improved her sleep, so we talked about sleep hygiene. We used some herbal sleeping aids, and talked about restorative exercise. So she was doing very intense exercise, lots of HIIT and intensive strength training, and that has a negative impact on your adrenal glands. So when you already have hypercortisolemia, elevated cortisol, and you exercise really hard, that results in more cortisol release, and that compounds the problem. So we focused on more restorative training, so more yoga, Pilates. We worked on strength training, but sort of low repetition, more body weight, and more cardio. And then we entered into therapeutic intervention. And again, this was done in a very stepwise fashion. Please note that when you have PCOS, especially when the picture is so complex, you cannot expect to fix it in a month. This takes at least between 6 months, sometimes up to a year, to really get your hormones back in balance. But once you do, you have that balance for the long term. So what we did is, first we cleaned up the gut, because we had to reduce all inflammation that was stirring up, starting immediately from the gut, and we improved her constipation and the bloating and all of those issues that she was experiencing. We supported her adrenal function, so already we started doing that with the stress resiliency exercises, but we also supported with things like ashwagandha and rhodiola to help balance that pattern during the day. We also very importantly worked on supporting liver detoxification and estrogen clearance. Okay, so we use things like DIM and curcumin and sulforaphane that's found in broccoli. We upped her B vitamins in order to support that phase 2 detoxification that she had a challenge with, magnesium, glutathione, and so on. And then we worked with progesterone replacement therapy, topical progesterone replacement therapy, in order to improve ovulation and counterbalance the effects of estrogen. And we supported healthy testosterone breakdown. So we worked on blocking that 5-alpha reductase enzyme that was producing that unhealthy testosterone. And things like saw palmetto, licorice, and so on are used, or spearmint tea are very effective. And so ultimately, everything that we were doing, we were trying to think of it as there are all these dials that we're trying to slowly move in order to bring the body into nice long-term balance. And so in 5-month outcome, actually, most of her symptoms were balanced. She has no issues with her gut anymore. Her periods are regular. They're no longer painful. Her mood is much more stabilized. Of course, she still experiences some stress given her age and everything that's going on with COVID, but she's working very hard on that to maintain that low. Her sleep has improved. Her energy's improved. She's back to training at a much higher intensity now. The only issue that remains is her androgens are still not her total testosterone, but her free testosterone is still slightly elevated. It's going down. That will take time as we bring the sex hormone binding globulin higher. So it's a really intricate balance, but all the hard work had paid off, and really I'm always really honored and incredibly humbled by the commitment that patients put into their health, and the support that her family also provided, and her mother in particular, in order to help her get through this and have a future healthy life where she doesn't have to worry about fertility issues or problems further down the line. So the key message here is, when it comes to hormone imbalance, please don't play whack them all. Okay, so if testosterone is high, I'm going to give aldactone. If the period is not working, I'm going to give birth control pill. Oh, let me just try metformin. Please don't. Test. Put your detective hand on. Test. Don't guess. Work with a professional that is willing to explore all the factors that are impacting your hormones. And then really focus on treating the biological terrain. Okay, so that's the environment in which your ovaries are placed in your the inside, the internal environment. We want to nourish it. We want to fix the soil. Okay, so that the hormones can thrive. And Andrea Nakayama is one of my favorite functional nutritionists. She wrote this as an entry into one of her programs. And she said that the roots that we look for exist in an environment or biological terrain. Okay, just as the roots of a tree grow in the soil, the roots of a health issue grow in an environment that is conducive to that particular problem. Okay, so it's I'm sure you've heard about the germ theory versus the terrain theory. In the germ theory, we think let's vaccinate the fish or give the fish some medication and then she'll survive in that dirty water. The alternative is, why don't we just change the water? Why don't we fix the environment so the fish can thrive? So ultimately, that's what we're trying to do in functional medicine. We want to uh, create an environment that's conducive to bring balance and harmony. When we alter the soil, we alter the roots, and this way we bring lasting relief. So hormone correction is an art. It's not just science. It's complex, and you need to be patient, and you need to be open, and you need to be willing to do the work. These are phenomenal resources that you can refer to. There's tons of information in these books. Whether you're thinking about supporting your period or learning more about your period, Beyond the Pill by Dr. Jolene Bryden is a fantastic book to teach you about how to help balance your hormones once you come off the pill. PCOS SOS is a great book by Dr. Felice Gersh, and she talks a lot more detail around the pathophysiology that underlies PCOS. And how you treat it. And you can follow all of these, by the way, excellent physicians on Instagram. They post regularly with amazing information. And then Wild Power is a fantastic way to harness more the spiritual energy that we have during the different phases of our cycle, and how we can leverage that for times when we need creativity, times when we need inward thinking, and so on. So I really encourage you. Any of these would be a great place to start. So thank you so much for your time, and we'll just open it now for questions.